morphine becomes contraindicated. Morphine must be avoided, and the alternative is oxycodone. Oxycodone is the opioid of choice in CKD or AKI. And when GFR is less than 50 mils per minute, you should switch oxycodone to subcut alfentanil. So in renal impairment, stop morphine, give oxycodone. If GFR becomes less than 50 mils per minute, stop oxycodone and give subcut alfentanil. In liver failure, oxycodone is contraindicated. However, the opioid of choice in liver failure, like cirrhosis, or in case of liver cancer, morphine is the opioid of choice. You should go for morphine. These are some opioid conversions. So it basically explains the conversions from morphine. So there are some important points I want to raise here. So I'll start with this one. So basically what it says is to convert from oral morphine to subcut morphine, half the dose. So divide by 2. So for example, if someone oral route is compromised and you want to switch the opioid to subcutaneous route, half the dose, divide by 2. So if someone is 20 milligram morphine in 24 hours, oral, and oral route becomes compromised, half the dose if you want to switch to subcutaneous morphine. So 20 divided by 2 is 10 milligram. In terms of converting morphine to oxycodone, as you can see, is twice as potent as morphine. So if you want to convert from morphine to oxycodone, divide by 2. And so on. If you follow these rules, you will find no problem with the calculations. Before prescribing any opioids, there are some important points. Starting dose, a typical starting dose of opioids is between 20 to 40 milligram. There's no max dose. That's why you gotta be very careful when converting and increasing the dose, because you don't want to cause any trouble like overdosing the patient. The breakthrough dose, this is a very important concept. So for example, if a patient is on, let's say, a modified release morphine sulfate, this means a patient takes morphine that acts on a prolonged period of time. So they take it, let's say, 4 hourly. In case they experience a sudden pain in those 4 hours, this is called a breakthrough pain. So you need to prescribe a breakthrough dose. And the breakthrough dose is always 1/6 the total daily dose. So the total daily dose divided by 6 will give you the breakthrough dose. Okay? So the breakthrough dose is any sudden pain that the patient experiencing while they are on morphine or modified release morphine throughout the day. So for example, if I take morphine 120 milligram in 24 hours, that acts 12 hourly, However, I experience sudden pains in the morning or in the evening, I need to take another dose. This is called breakthrough dose for breakthrough pain to treat my new pains, my new sudden pains. So to work out the breakthrough dose, it's the sixth of the total daily dose. So if I take 120 milligram daily and I experienced a breakthrough pain, divide the total daily dose by 6. So 120 milligram divided by 6 is 20 milligram. So for any breakthrough pain, for any new pain, I should take 20 milligram. 20 milligram. Okay? Modified release means a drug is delivered for a prolonged period of time. Immediate release means immediate action. This is the first question. A 60-year-old lady with metastatic endometrial cancer comes for review. She is currently taking MST, morphine sulfate, 70 milligram twice daily, but is unfortunately troubled with pruritus. You therefore decide to switch her to OxyContin, slow-release oxycodone, which is taken twice daily. What dose of OxyContin should she take twice a day? So basically, this patient is on morphine, and the question asks you to convert it to oxycodone. So this question of conversion, the first thing we should know is that oxycodone is twice as potent as morphine. This means to convert from morphine to oxycodone, divide by 2. So oxycodone is twice as potent as morphine. And the total daily dose of morphine is 150 milligram because he's taking 75 milligram twice daily. So the equivalent dose of oxycodone, you divide the 150 milligram by 2. Here, they divided it by 1.5 because this is the BNF conversion factor. You can still divide it by 2. You will get 100 milligram, so it should be taken twice daily, so 50 milligram twice daily. Question 2, a 56-year-old has chronic pain, which well controlled on fentanyl patch, 26 micrograms per hour. However, he has developed a rash around the application site, so the injection site, that is not improving. Following discussion with your patient, you decide to switch to modified release morphine preparation. His pain is well controlled with fentanyl patch. Prescribe a suitable dose of morphine for this patient. So the question asks you to convert fentanyl patch to morphine. I want to stop here and take you to a good source of opioid chart conversion. So basically what they are asking is, they want us to convert fentanyl patch to morphine. This means if you want to convert morphine to fentanyl patch, you should divide. Why? Because fentanyl patch is stronger than morphine. Because always remember, to convert from a weak to strong, always divide. So fentanyl patch is 3 times as potent as morphine. Let's go back to the slides. Yeah. Fentanyl patch is 3 times as potent as morphine. Okay? Here, they didn't divide, but they times 26 by 3. They multiply it by 3 because if you want to convert from weak to a strong, you always divide, and vice versa. So if you want to convert from strong to a weak, multiply by 3. So 26 times 3 is 78 milligram. If you round it up to 80, that will make 40 milligram twice daily. I'll send you the conversion chart in the group so you can use it when you answer these questions. Question 3, 71-year-old man with metastatic prostate cancer presents for review. His pain currently controlled with paracetamol 1 milligram QDS, ibuprofen 400 milligram 1 gram QDS, ibuprofen 400 milligram TDS, and Zomorph 60 milligram twice daily. However, he was complaining of the same pain this morning. Calculate a suitable dose for his pain. So the only opioid he is on is the Zomorph. We don't care of the non-opioid medications when you calculate opioids. Just focus on the morphine. So this patient is on modified release morphine, 60 milligram twice daily. So the total daily dose is 120 milligram. Okay? This patient experienced a new pain. This is a breakthrough pain. You need to get a breakthrough dose to treat this pain. The breakthrough dose is 6th the total daily dose. This means 120 milligram divided by 6. So the total daily dose is 120 milligram. The breakthrough is 6 the total daily dose. So it's 120 divided by 6 gives you 20 milligram. So whenever this patient experiences the pain, he should take 20 milligram. If you supplied him with a bottle of Oromorph solution with a concentration of 10 milligram per 5 milliliters, what volume should he take for his breakthrough pain? You just need to cross and work it out. So if 10 milligram has 5 milliliters, then 20 milligram means 10 milliliters. So this patient should take 10 milliliters every time he has the pain. Question 4. A 65-year-old man on palliative treatment for metastatic esophageal cancer is finding it increasingly difficult to take his morphine, and as such is in increasing discomfort. His current prescription is 60 milligram twice daily oral morphine. What do you want to do next to manage his pain? So this patient has esophageal cancer, and he has a lot of discomfort, maybe because he isn't able to swallow it, or it's painful to swallow the oral morphine. So you need to consider other routes of administration. So the oral route is compromised. So you need to switch to subcutaneous route. And remember to halve the dose from oral to any parenteral dose. So any parenteral route. Okay? So patients should be on a syringe driver for subcutaneous morphine. Okay? So the total daily dose is 120 milligram. If you want to switch to other parenteral route, always half the dose. So it's gonna be 60 milligram in 24 hours. Is that clear? Because the concept is, if the oral route compromised, switch to parenteral route. And when you do that, half the dose. This patient takes